My case is a 54-year-old patient of chronic coronary syndrome with hypertension and diabetes, admitted in our hospital for PCI to CT of RCA. In ECG, there was ST segment depression in the inferior list, and in echocardiography, there was inferior hypokinesia with an ejection fraction of 46%. So angiogram was done in another hospital through femoral route 1 month back, where the left system was normal and there was CTO in the mid part of the RCA. So we plan to do the PCI in radial route. You can see there's tortuosity in the subclavian artery and there was difficulty in engagement. Ultimately, we could engage the coronary artery with JR catheter. RCA is an ugly looking vessel with disease from the proximal part, and there was 100% lesion in the mid part. There was a faint line of dye just in the anterior flow, so we didn't took the contralateral picture. Ultimately, we could cross the lesion with pilot 150 with the aid of a fine cross microcatheter. We pre-dilated the vessel with 212 balloon at 12 atmosphere. Then we took picture. We can see there is frank spillage of dye in the mid part. So there was a perforation. Very quickly, we wet down a balloon, and after prolonged inflation, the perforation sealed, and we stented the vessel with 2.75 32 millimeter stent. You can see after stenting, the perforation sealed, but there was a long dissection proximal to the stent. So we took another stent of 3 into 18 millimeter. We stented the proximal part, but we missed the proximal entry point of the dissection. To seal the proximal entry point, we required another 3.5 12 millimeter stent. And after that, this is the picture. Both dissection and perforation sealed, and this seems to have a significant lesion in the ostial part of the PTA. So another stent was required, and this is the final picture. So the learning points, there's a lot of obstacle in this case. There's difficulty in engagement, then crossing the CTO. After crossing, there was perforation. After we seal the perforation, there was dissection. In this type of cases, we should follow this Forest laws. The operator should be emotionally stable. The patient should be kept hemodynamically stable. Both the guide wire and guide catheter should be stable, and the operator should be smart-headed and to take the right decision, and he should be swift to call the other medical staff. Ultimately, stenting is the bailout strategy. There are different type of perforation according to the location. Whatever may be the location of the perforation, we should follow this universal algorithm, that is inflate balloon to occlude the vessel and maintain the patient hemodynamically stable with intravenous fluid or vasopressor, pericardiocentesis if hypertension, and then notify the surgeon if there is persistent extravasation. And in case of large vessel perforation, we should try out the prolonged balloon inflation. If we fail, we can try with covered stent or dissection technique. In case of distal vessel perforation, we can try with embolization or covered stent over the perforated branch. If there's continued extravasation, we should reverse the anticoagulation and send the patient for surgery. In case of dissection, in case of minor dissection, may not require any treatment, but if more than 50% stenosis with impaired TME flow in a vessel more than 2.5 millimeter, it should be considered severe. In our cases, we are lucky because we had wear in the vessel, but most difficult part of treating the dissected segment is wearing down. So if we attempt to wear down, we should take a soft varicose wear with a low tip load, and we can take the help of IVUS. If we're in the true lumen, we should stent the dissected segment. If we're in the false lumen, we can try that IVUS guided rewiring. If we fail, if the patient is hemodynamically stable, we can treat the patient conservatively. If we fail, we can try some bailout strategies such as parallel wear plus straw technique, bailout strategies, retrograde approach, re-entry with stingray, and wire-based catheter re-entry. If we still fail, we can send the patient for cabbage. So we had a lot of suffering in this case, but we have learned also. So at the end of the day, I console myself that a smooth sea never made a skilled seller. Thank you all for patience.